Welcome everyone to the Dr. Meade Show. I'm Sam Lesante. I'll be your moderator today. And of course, the main man is Dr. Tom Meade himself. Reason why I'm moderating is some very interesting things happening in the field of orthopedics, particularly in the field of total knee replacements. Well, Doctor, thanks for having me on your show, and let me moderate this, okay?
You're very welcome.
From what we were discussing, in the next 10 to 15 years, there's going to be over a 700% increase in total knee replacements. Where are we at now?
Sam, it's an explosion. There's approximately 1 million total knees and total hips done per year. 600,000 of those are total knee replacements. It's estimated that that's going to increase to 3.5 million total knee replacements by 2030. As you said, a 700% increase. So we better figure out a way to do this better, faster, less expensive, and get better results, because this is a huge expense to our healthcare system.
Now, when you're talking about the demographics, it's a surprising thing here. These are not people who are either 80 years old or 7 years old, correct?
Well, it's interesting. The largest percent growth of that group is actually the 40 to 50-year-old patients, not what you're thinking, although in absolute numbers, it would still be the Medicare population, you know, the 60 to 90-year-olds. But the absolute percent increase is greater in the 40 and 50-year-old age group. These are the young, active patients, the baby boomers, the old sports injuries. They've had previous ACL tears, partial meniscectomies, and certainly the obesity crisis comes into effect this as people are heavier, both mechanical and chemical inflammatory agents just age the knee, and it's just accelerating.
Okay, now you're the #1 orthopedic surgeon in knees, maybe in the state of Pennsylvania. I mean, it's amazing the thousands upon thousands of knees that you have done. Now, being where you are, all right, there has to be new techniques that you are involved with. Could you share with our viewers, what are some of these new techniques that are available?
Well, Sam, some of the greatest advances in knee surgery are still evolving, but what's really helping out this whole subspecialty is the fact that we're figuring out how to get a better patient experience and a better result. We are doing a lot more minimally invasive surgery, so our incisions are a lot smaller. We're doing quad tendon sparing surgery. We're not cutting the tendons anymore. We don't, we use techniques where we don't use the tourniquet anymore, or minimal tourniquet. So there were times when they'd put a tourniquet on the leg and stop the blood flow for 1 or 2 hours. The amount of tissue trauma and pain that would involve is significant.
You're not doing that now, are you?
We're not. No, we've stopped using the tourniquet, or we use it very, very minimally. So there's a whole bunch of different technique and tools that you need. So you don't want to, if you're not using a tourniquet, you're going to get bleeding, of course. So we have a whole bunch of different techniques and tools to stop the bleeding. We have agents we give the patient. We use different electrical tools to stop the bleeding. So it's so exciting. But all these techniques have actually allowed us to do a certain percent of knee replacements as an outpatient. If you could imagine, when I start training, people are in the hospital 7 to 10 days. This week, I did a woman at 7 o'clock. She was home at 9:30, a total knee replacement. Sam, these techniques are absolutely phenomenal. Now, they're not for everybody, and we have assessment tools that can actually predict who will be a successful outpatient total knee candidate. So you don't want to do it, send them home and have them bounce back to the hospital. But with the right selection techniques and the minimally invasive techniques, the better anesthesia techniques, and something called multimodal pain management, we are not waiting until patients have symptoms. Historically, what did we do in medicine? Well, if you had pain, we would treat the pain. We would give you something for pain. If you got sick to your stomach, we would treat you for nausea. Now we're giving preemptive medications. We're anticipating all these things. Before the patient comes in the hospital, we are loading them up with safe, non-narcotic analgesics for 2 or 3 days ahead of time. As soon as they hit the hospital, before the surgery, they get these anti-inflammatories, these analgesics. We have special IV techniques. We have patches that prevent nausea. So post-operatively, their requirements for narcotics go way down. So we've just rethought our whole approach to figuring out what symptoms they're going to get, preempting it with the appropriate techniques, and including, remember when you couldn't have surgery, they said don't eat anything or drink anything after midnight?
Yeah.
A lot of this old dogma has gone out the window. We now want people to drink right up until surgery, 2 hours before surgery, because we find out if they're hydrated, they don't have blood pressure problems, they don't get dizzy, they can get up quicker, they could go home quicker, and they don't get nauseated. So look at the things that we've told people to do for years, and now we're reversing this, and it's to their advantage. But we have to have these techniques. We don't have enough hospital beds to handle 3.5 million total joints. So unless we figure out how to shorten the stay, give them a better patient experience, and even have a certain percent as an outpatient, we're not going to be able to handle the supply of patients needing joint arthroplasty.
Throughout your years and the thousands of knees that you've done, okay, how does that lend you to the lending process? You know, in terms of then, you know, knowing, well, okay, what you did 5, 10 years ago, and now as you grow into these innovative techniques.
Well, you know what's interesting, Sam? It's sort of interesting. My practice is more common in Europe than it is in the United States. In Europe, they have specialists in the joint. Like I do knees from 15 years old to 99 years old. In Europe, they have knee specialists and hip specialists. The way they train in this country is they do joint replacement specialists. So people will do hip replacements and knee replacements, but they don't concentrate on one joint. So there's very few people that sort of gravitate it, or what I say, have the privilege to just do one joint. And so that gives you a whole lot of experience. In 1 or 2 years, you sometimes have the experience that some docs may not get, in their whole life. So it allows me to look at a whole cadre of patients, experiences, and plus I get to travel in those circles with people not only in this country but internationally, and you're always exchanging ideas. You're having roundtable discussion, what works, what doesn't work. You could vet it with multiple surgeons. So it allows you to travel in those circles and bring that experience back to my hometown of Pittston, and they don't have to go to New York or Philadelphia or somewhere else.
I often wanted to ask you this, as many years as I know you, and you have your own TV show, which I'm on. How is the learning process work for you? As far as you said, you go and you meet different people and learning all these new techniques, and listen, the proof's in the pudding. You wouldn't be the number one orthopedic knee replacement surgeon if you weren't doing the right things. How do you learn about these different things?
Well, Sam, you have to challenge yourself. The easiest thing is to get complacent with what you do it very well, and you keep doing it. That's the whole problem with knee replacement in this country. Approximately 1 out of 4, 1 out of 5 total knee replacement patients are not happy. They didn't really get a good result. But if you went to a restaurant and 1 out of 4 meals wasn't good, you wouldn't go back to that restaurant. Yeah. But that's the situation in the knee replacement world. So you have to be one of those people that push the edge. You want to be out there and say, how can we get not 80% good results? I want 90% good results. I want 95% good results. So you have to look at what we do is very predictable. It's been done for 50 or 60 years, but there is room for improvement. And it's not just one aspect. It's not, you have to look at the prosthesis you're using. What innovations could we use? How do we put it in? What instruments do we use? What incision do we use? How can we make it smaller, less traumatic? And just like I talked about, you look at every variable from when you first meet the patient until that patient is 6 months to a year down the road, and you dissect that out, and you discuss that with people around the country that want to make it better. And I mean, we need well-trained orthopedic surgeons that are great technicians that get out there and do it, but not everybody has the opportunity to be out there and challenge themselves and really be humble enough to say what we do is not perfect. Why, we are not perfect. We have to improve this, and then change is very hard. Surgeons, people in general, don't like change. You say, well, geez, I'm doing pretty good at this. I'm right with the rest of the country. We're getting, 4 out of 5 patients are happy, and to change, you're always taking a risk. You're saying, well, is this going to work or not risk? But I think with good thought and good people and good discussion, we're pushing that envelope and we are getting better results. It's better for the patient. We have less complications. We know no matter how you look at it, no matter how good that hospital is, the longer you're in the hospital, the higher your risk of hospital-related complications. So if we could predict how to get you out of that hospital quicker, how to limit your operative time, the OR time, the anesthesia time, you're going to do better. And that's really how you learn. It's that passion to constantly get better.
You said something about the fact that sometimes some people who did not go to you or didn't coordinated health and had a bad experience. So now you have a person that needs a knee replacement and they're worried and concerned, okay, about, am I going to have a bad experience like that person? First of all, find out who did the surgery. That's my first thing is, don't throw all orthopedic surgeons in under the bus because one person, didn't do a good job. What do you say to those people who are hesitant?
Well, let me tell you, I always said 2 things in life humble me, sports and surgery. As soon as you think you're good at either one of them, something's going to come along and put you in your place. And in surgery, unlike carpentry, it's not predictable. We could do the exact same technique on every patient, but Mother Nature takes over. The biology of healing, and everybody is different. Their own genetics are different. Their own immune system is different. There's some people that are sensitive to metal. So as soon as you get on your high horse and you think that, you're good, there are many, the vast majority of orthopedic surgeons really in Pennsylvania. The Wyoming Valley has tremendous, well-trained orthopedic surgeons. But as soon as you get on your high horse, you have to sort of look and say, what are the other variables? And we have a lot of comorbidities right now with people that are older, they're diabetic, they smoke, they're above their ideal weight, they have sleep apnea. All those things can really throw a wrench in the work and cause complications. So it's not just up to us. We try to predict those, but nothing is risk-free. There will never be zero risk, but we just try to identify the risk and cover those as much as we can.
You've always stressed teamwork, okay? How does coordinated health play a major role with Dr. Tom Meade in the successes that you have with the many thousands of knee replacements you do?
So, in 2 ways. That we have a very, very dedicated team. So coordinated health affords us the ability to let people do what they like. You want to get up in the morning and do what you like, So just like I do knees, my whole team just does knees. We have, 4 or 5 PAs on our team that just do knees. And, they'll see more knees than family practitioners. They'll see, more knees than a lot of general orthopedic surgeons do. So they're very good at what they do. But they also teach very well. So you want to incorporate the whole team. You want to incorporate, everybody that answers the phone to know that what we do is patient-oriented. Everything that we do is to give that patient a better outcome and a better experience. So, we educate our whole team from the front desk to the nursing staff to the preoperative area to the OR staff to the perioperative area. We have our own hospitals, but we control it. When you could control that, you're going to get a better result as opposed to, if you go to, and I work at a few hospitals, and when I go there, I never know who's going to show up in the OR. But again, we work at different places, and there's some folks that can't leave their community, so we're happy to go to their community hospital, and we bring our team, so surgically it's okay. But, they just don't do knees on that floor or that OR, and they don't have all the equipment, and you can just tell the efficiency isn't there, things take a little longer. And so, your risk of things not going as they do in a well-oiled machine go higher. So to have a team that is just focused on what you do, and coordinated health, we do that in not only what I do, but in people that do backs, people that do women's care, people that do hips. It's the same team concept throughout the whole coordinated health.
Folks, you're watching the Dr. Meade Show. I'm Sam Lesante, moderator. We'll come back. We'll talk about the expansion of coordinated health and an area where Tom Meade grew up and what an exciting thing it is for Wyoming Valley. Stay with us. Welcome back to the Dr. Meade Show, folks. I'm Sam Lesante, your moderator, along with your host, Dr. Thomas Meade. We're talking about a lot of interesting things in orthopedic surgery, particularly in the knee replacements. We said in the first part of the show, Doctor, that there would be a 700% increase in total knee replacements over the next 10 to 15 years. What are some of the things that research is doing now to help with knee replacements, etc.?
Well, research is critical. I mean, you really have a responsibility. If you do a high number of procedures, you really have an obligation to measure your outcomes by standard tools so that you're doing evidence-based medicine, and you want to contribute to that literature. So at the volume that we do, I'm fortunate enough to be able to hire a full-time research assistant. So every single patient that we do a knee replacement on will see our research assistant, and we will follow standard research tools beforehand, and we will follow these every month, 3 months, 6 months, and 2 years to measure our outcomes. And the value of that is we could look back and measure any parameter that we want that we put in, if we have good data putting in. But it also allows us to travel in those circles with other surgeons that ask the same questions. And then we can do what's called prospective randomized studies. So we have several prospective randomized studies where if we want to study a different alignment technique, let's say, where the way we put the knee in is a more natural or a more mechanical approach, if we're using different instrumentation. And right now, we're doing several of those prospective randomized studies. We're doing some with the Rothman Institute in Philadelphia with Dr. Parvizi and Dr. Sharkey. Dr. Parvizi's head of research down there. So it allows us to really extend our data to some of these other institutions. We're out with some docs in Phoenix, Arizona, doing some prospective randomized studies. So any question that we have, are we going to improve total knees? Is it better to do, is there any risk to do an outpatient surgery? Which patients are the best for that? Which pain medicines work better? Which injection techniques around the knee work better? And we just studied 2 different types, and we could set that up in a prospective randomized study. So that's the fun part of being able to travel in these circles, and it's how research advances the field of knee arthroplasty.
Extremely valuable. So the thousands of cases you've done, okay, I know I take the PRN fish oils every day, okay? Yeah. And the people who I've been telling and who has been using them over the years have seen a tremendous response. Well, you're the knee surgeon. What do you see when these people are using their PRN fish oil?
So it's one of my hobbies in medicine besides knees is omega-3s, and we always go back to 2004 when they took the anti-inflammatories off the market and we start using it. And anecdotally, we knew that it worked. But just like in medicine, I can tell people it works unless we have good prospective randomized studies. And actually, that's one of the studies we're doing with Jefferson. So you get one of the head researchers at Jefferson. We have decided to do a prospective randomized study, something that we know anecdotally works. But you know what? For us to go out there at a national meeting and talk to a bunch of orthopedic surgeons and tell them that omega-3 and certain natural additives are good for osteoarthritis, for credibility, we better have a good study. Even though there's hundreds and hundreds of studies out there that show it's good for your global health, the gold standard is a prospective randomized study. The same thing happened in the eye world. Everybody kind of knew that it was good for vision and dry eye. Well, PRN actually did a prospective randomized study that proved that brand of omega-3s helped with dry eye, and now it has become the standard of care with ophthalmologists across the country. Well, we're attempting to do the same thing in orthopedics, where we actually take patients with osteoarthritis that aren't on fish oil, and we take some fluid from their knee, and we take some blood from their arm. We measure their inflammatory mediators, and then we put them on fish oil for 3 months, and then we repeat the test. And we're right in the middle of that, and the early results look very, very promising. So it's exciting.
So we got good news. I mean, you're always excited. I mean, I haven't not known you to be not exciting, but Dr. Meade, folks, incidentally, as we're speaking, you know, the numbers on the screen. You could certainly give him a call, #1 knee surgeon. I'll tell you, the guy is phenomenal. So you are now in your hometown. You're in your hometown of Pittston, okay? A town that's true and dear to you and your entire family. Well, I'm going to ask a very dumb question now. Of course, I ask a lot of dumb questions. How does it feel to be home?
It feels great. It's been on my professional bucket list forever. Before, my career ends, and that hopefully isn't going to be for several decades, I always wanted to go back home. I actually almost went there right out of fellowship, but that didn't work out. I ended up an hour away in Allentown, which was close enough, but I always wanted to go home. And now, the stars have aligned, and, you reach a point in your career where you're actually contributing to the field, and you're on the cutting edge, and to be able to bring that back to your hometown. And the Wyoming Valley is a great place. For years there's been a brain drain up there. We're good, smart people that I went to high school with. They couldn't wait to go to college and get out of there. Well, that's reversing now. They have their own medical school, they have great education, great colleges, but it's going to take some time to populate that. And there are some great orthopedic docs up there, and if we could add to that skill set, it just is so exciting to bring some of that back.
And I think because, you have this will be your 17th location for coordinated health, correct?
Yes.
I think is. And so with 17 locations, being the leader in the state of Pennsylvania, at least for care, #1 care, from what I understand, coordinated health has. Now being able to take that expertise in Pittston, you have it in Hazleton, you have it in Allentown, you have it in Lehighton, and God knows all the other places that you have it. You are there. So what? Now that you're in Pittston, what will you be doing there?
So, we're going to stage this. So the first thing we need is an office. Just because I'm from that area, I see a ton of patients that come down to Hazleton, Lehighton, Allentown. So it's great, so they won't have to travel. So now we're going to have an office up there, and it's just not me. We're going to have multi-specialists up there. We're going to have X-ray, radiology, physical therapy. We're going to have foot and ankle doctors. We're going to have physiatry. We're going to have women's care. We're going to have back care. And that's just, when we start there. So, I think there's definitely a need, especially in Pittston. Pittston seems to be the abandoned child up there. It's almost like, Allentown and Bethlehem, and never the two shall meet in the Lehigh Valley where the river goes through. Well, up there, it's almost the same thing. You have, a lot of great docs in Wilkes-Barre and Scranton, but Pittston, everybody kind of abandoned. So it gives us a chance to go back to Pittston. There's no orthopedic surgeons in Pittston. There's no, big multi-special group like Coordinated Health. So that's where we're going to start, and I can't wait to get started.
I can imagine. Folks, you're watching the Dr. Meade Show. Yes, I'm not Dr. Meade. I'm your host. I'm the moderator, Sam Lesante. 877-247-8080 is how you can get in contact with Dr. Meade. We'll be back right after this message. Welcome back to the Dr. Thomas Meade Show, folks. Dr. Meade Show. I'm Sam Lesante, the moderator, along with your host, Dr. Tom Meade. 877-247-8080, leading knee replacement orthopedic surgeon, I think, in the country. So what do you say to patients who are now looking for some of the skills that you have that are not available in the area? So,
Sam, as you know, you rushed me out of my office to get over here to do my show today. So, but just today I left the office, and I had a couple of patients that were really frustrated, and one patient came from the VA system, and the VA system has been getting a lot of heat around the country for having a lot of issues. Just access to care, and there's my whole family was in the military. My dad was in the military. I have the ultimate respect for these soldiers. They do a tremendous job. I couldn't say enough. So anything we could give back to them. We saw, a guy today was in the Army for 9 years, was discharged on a medical because his knees hurt. So he got discharged because his knees hurt. He had multiple surgeries on his kneecaps. He went to the VA system up there, and they have limited resources. They can't have every specialty. And basically, they couldn't help him. And he needed partial knee replacements, but a special partial knee replacement, just the kneecap, which not too many people do. And so all they said we could do was send you to New York. And so his next appointment was 3 to 6 months from now. And that's the problem with the VA system. They're not that efficient. So he came down today. Indeed, he was in his 40s. His knee has advanced arthritis, but only in one part, underneath the kneecap. So the best option for him, he's a carpenter, he's a hardworking guy in the military, got a medical discharge and multiple surgeries, needs a partial knee replacement. They sent him to New York. We saw him today. We evaluated him. He's on the schedule for 3.5 to 4 weeks from now. So in 4 weeks, he will have a new partial knee replacement. He would not even have an appointment in New York City with the expense. And this guy, they don't have a lot of money. He only works, he's laid off in the winter. So that's one example of what we could bring 3 or 4 miles from the hospital up in Wilkes-Barre.
I'm sure you could write many, many books on what you've experienced. The thing is, with coordinated health now, being the leader in the state of Pennsylvania, as I say, no one gets to where they are unless they have paid their dues and has done things right. You did not get where you are, Dr. Tom Meade, being the person that you are in total knee replacement, probably the best, if not the best, in the state of Pennsylvania. And so it's beautiful to know that we know in this our area that we have people like you and the team that you have, because you got ankle, you have breast, you have plastic surgery. I mean, there's a whole array of things. Well, we're running out of time on your show.
Wow.
Oh,
wow, that went so quick.
Doesn't your show go fast?
I know. Was I the moderator?
Yeah, I'm the moderator.
Oh, you're the moderator.
You're the host.
Okay.
Folks, it's always a pleasure to be on Dr. Tom Meade's show. I'm your host, Sam Lesante. Remember, you can watch all of Dr. Meade's shows, Real Life in the OR. That's another show that's fantastic, on ssptv.com. All of the shows that we do for Dr. Meade, that MDTV is an associate with us on Real Life in the OR, as well as the Dr. Meade Show. His number is 877-247-8080, and he'll see you next time on the Dr. Meade Show.